All right, well, good morning and welcome to Grand Rounds. I would like to express our gratitude to Dr. Jim Korndorffer, who will be speaking on the behalf of the board regarding entrustable professional activities. As many of you know, the board is launching a new evaluation system for our residents, and this is coming in July for the next academic year. It's going to be initially rolled out in general surgery, but there are plans in the next few years probably to include CT, vascular plastics, and pediatric surgery. So this subject is very timely and applicable to us all. Dr. Korndorffer is currently Associate Professor and Vice Chair of Education in the Department of Surgery at Stanford. He previously served as a Program Director, Vice Chair of Surgery, and Assistant Dean for Graduate Medical Education at Tulane. In addition, he also is the Medical Director of Tulane Center for Advanced Medical Simulation and Team Training. He received his undergraduate degree in biomedical engineering from Tulane, his MD from USF, and his master's in health professions education at University of Illinois. He completed both his general surgery residency and MIS training at the Carolinas Medical Center. He is actively involved in numerous surgical societies, serving in many leadership roles, and has received multiple prestigious honors and awards for his service over the years. In addition, he's published over 60 papers, authored many chapters. His research interests mainly include surgical education and simulation, patient safety, and care quality. Dr. Korndorffer has been a member of the American Board of Surgery's core team and has been involved in the development of the 18 EPAs that we're going to hear about today for general surgery. He will start us off with the why, what, how, and so what of EPAs. And then following our Dr. Deborah Marquardt, one of our esteemed associate program directors, will talk about the specifics related to our local program rollout. As many of you know, Dr. Marquardt is an associate professor at the VA, and she's definitely an integral part of our general surgery residency education program leadership team, and it has been for many years. Dr. Marquardt is serving as our champion for the EPAs with this new initiative, and has been working on this initiative over the past year. So we strongly believe that this new evaluation program is a tool and a big step forward for our residency program in regards to optimizing our feedback process. So without further ado, we'd like to start off with Dr. Korndorffer. Welcome.
Great, thanks, Dr. Peterson. I really appreciate the opportunity to talk on this project, which, when the board put it together, I really do believe this is a generational opportunity to improve the training environment for all of our trainees and the surgeons of the future. I have nothing to disclose pertinent to this talk, other than I will say I did do work, as mentioned, with the EPA writing group and worked for the board. And as many of you, the guys that have done stuff for the board, as you know, that actually work was done for either free food and or the camaraderie, but certainly no monetary reward from that standpoint. What I want to get to today is hopefully cover the why, the what, the how, and really get a little bit into the so what as well. Why is this being done by the board? A little bit of what the EPAs actually are for those of you that aren't completely familiar with them, at least how it's structured. Talk a little bit about how some people have implemented it and are planning on implementing, but of course, most of that will be on the local project as well, as opposed to national. And then talk about what the significance really is. Number one, the EPA is not what you think of as the EPA, which meaning the Environmental Protection Agency. So we're going to make sure you know that at the end of this. So the why EPAs, and as you see here, there are a lot of reasons behind this, and I'm going to go through each of these individually. But what you really want to think about, this is really a strategy that it's really robust because it has an ability to address a lot of these critical issues that we've been dealing with as learners and educators over the years. And so I want to go through each of these just briefly. With respect to feedback, number one is that many of you are also aware that one of the first competency-based residence education models was done at the University of Toronto in the orthopedic residency. And with that, a large part of that was an EPA-based clinical assessment model. And what they found out was that the opportunity to use the EPAs provided that opportunity to give you that timely, actionable feedback in close proximity to those observed performances. And what was noted was by doing this, that actually the feedback increased fivefold to the residents. And I don't know about you, but certainly every year on our ACGME survey, one of the areas where, well, we're doing okay, we can always do better, is oftentimes the residents talking about need for better feedback. Now, the second reason for EPAs is a mandate to move forward toward that competency-based rather than time-based residency education. And, this has been talked about really all the way back to 2002, and if not before, when the Blue Ribbon Panel was put together, convened by the ASA and the ACS. And at that point in time, that group, amongst others, as you see here, did have several recommendations, including defining a national curriculum. That's been done, right? That's now the SCORE curriculum, which is also part of the board at this point. It also called for a strategy to verify competence at each level of training as they move forward. And that was one of the key aspects to dealing with a competency-based reform. And then specifically on the bottom, you see, it's like there was a specific call out for verification and the need for meaningful assessment strategy to be created. That's really where the EPAs can play into this role. In fact, when you look at the idea of a core component of a competency-based medical education, having some sort of framework really defines that desired outcome is a key aspect of this. As you see in number one, it's like the outcomes framework, competency framework is critical if we're ever going to start. We talked about before we even got started on this, or we were talking before the everybody else got on, that without that assessment, there's no way of moving toward competency-based medical education, which I think we all would agree is the next step. And this move to competency-based training has been, quote, gathering steam really probably for better than 70 years. It's interesting. Richard Resnick said at one point in time, I heard him talk, it said that competency-based medical education has been taking the medical education world by storm for the last 30 years. So that storm is still brewing, but it's taking a long, long time for us to really move forward. And a lot of that really does have to do with the fact that, okay, we believe this needs to be done, but how do we assess it so we can actually accomplish that? So if you think of it another way, our current system offers one path to surgical training. Spend 5 years, 7 if you're doing research, 8, whatever it may be. And you know what? At the end, you're a surgeon. But unfortunately, individuals tend to acquire knowledge, skills, and attitudes and abilities at different speeds, right? Some don't necessarily have that straight path that it needs to be. And so our fixed time system, unfortunately, winds up where you have somebody almost ready, somebody completely ready, and somebody that still needs a little more work. Not somebody that necessarily needs to go on to do something else, but actually just needs a little bit more time to get there. And in this situation, our ideal system was we need to define what's required to become a surgeon first and ensure that all graduates that are competent to perform these minimal basic requirements before they transition into practice. And we focus on and fix the outcomes at the end of training. And that although logistically may be challenging, especially in our situation right now, how GME is paid for, certainly, certainly we would all agree that this whole concept is an area where we need to move forward. So we have that fixed outcome, and no matter how long it takes, we continue to work that person, those people, to where they go. And I would argue, and actually it is identified again back in the Toronto experience, several people actually finished early. So we always think about the individuals that actually are late or take a little more time, but several of them finished their training earlier rather than later. And wouldn't that be a nice thing? Well, another reason for EPAs as a component for competence-based training is that concept of that public trust, right? That we want to make sure that the public we have an accountability to those that we serve. And none of us really would actually go and pick our surgeon out of Yelp or the Yellow Pages as it shows here, which is an antiquated version, I must admit. But if we were somewhere else, right? And unfortunately, we have a lot of information that we can use when we pick, but unfortunately, the public doesn't. And so that's really where it is. It's very critical that we need to make sure that public trust is put in this whole process. And again, this is another area with which EPAs really can make an effective difference, right? That we can know that the individuals, the trainees, those that are going out, we can entrust them in these certain areas. Now, many of you also are aware the consistency of training product is been called into question. I'm not sure I completely agree with some of these, but that's my personal bias, not otherwise. But, fellowship program directors and other end users, and even in the lay press, have talked about the fact that there's a concern with respect to confidence and readiness for practice. In fact, we did a survey that of residents finishing, and of some of the 10 most common operations performed in residency and actually in private practice once you first get out, of those 10, the chief residents halfway through their year, only 7% actually felt self-efficacious in all 10. We also looked at the program directors and what they thought as well, and interesting enough, it very closely mirrored that as well. So I do think we have an issue we need to deal with. Whether it really is their, the concepts of not being ready is a different situation, but certainly that confidence level, that self-efficacy is an area we can certainly work on. So, additional reason why we think the EPAs are valued specifically in this situation is this can be done during your normal workflow. This is really how we do things on a daily basis, right? I will say this is like, if you guys are anything like we are, I think we can handle the medical knowledge and the patient care side of things. We do that pretty well, right? We can evaluate that. To some extent, I think we can do a decent job nowadays, actually, as these competencies came in with respect to looking at interpersonal communication skill and even professionalism. There are plenty of areas we can look at that. But I would argue that as we move forward beyond that, when we start talking about the concepts of systems-based practice and practice-based learning and improvement, these are certainly areas that are, how can you figure out or describe the skills that are present at that point in time? We use a Yogi Berra quote, and it says, in theory, there's no difference between theory and practice, but in practice there is. So this is an area we can work on, and I think the EPAs really can make an effective difference and actually look at these as well. And so this really gets us to the idea of why it's important, going back to that assessment side of things. In business, they say that what gets measured gets done. Well, in education, there's no doubt that assessment really does define the goals of education and whether they're actually being met. It also really orients not only the learner, but also the teacher. And without meaningful clinical assessment model, really what we're dealing with is kind of bowling without the pins down at the end. Final reason with respect to EPAs, looking at the concept here, is the importance that entrustment is really founded on some basic characteristics of a true professional. And I really want to focus on one. And you need to think about this, is an EPA it's entrustable professional activity, but there's one big part of that that really is important that you don't want to miss. And I'm going to go all the way down to the bottom here, which is that humility. Part of that EPA, part of that entrustment really is ensuring that you can trust that the graduate, the trainee, either actually can recognize their limits and they're open to feedback. And that's another key aspect to this. And I think this is where, again, we were talking earlier, where it's a big part of the cultural change, that we need to have that aspect of it in as well. So understand that's a big part of this. And then the key here is remember, we're not focusing here on a simulation or multiple choice exams. Those are there. They do have their place, don't get me wrong. But what EPAs really help us do, they help us focus beyond that concept of knowledge and skills and the knowledge and skill acquisition specifically, but to the actual application of those knowledge and skills. And they do this really by focusing that assessment on real-time, everyday workplace, and the activities that the surgeon is doing on a regular basis. And that's, again, where the shift comes in. It's not this one-off, it's not somewhere else, it's actually in the day-to-day work. And this really is where you can get focused on the concept of that application of that knowledge. So with that as a background, you want to move from the why, but this is really the what. What is an EPA? And many of you probably are very well aware of this. You probably heard quite a bit about that. But what we're going to talk about here is that an EPA is really an essential task. In our case, really in the discipline of surgery, that someone can be trusted to perform independently. And it's important, though, it's in a specific context, right? It's where it is and what it is. Now, accordingly, the set of EPAs, if you think about it, then if you put this set together, really can define the core of a specialty or discipline. And the point being here is it's the core, right? They allow us to move the focus of assessment from this abstract concept of competencies that we have to something that is more tangible. Now, an EPA accordingly is really that integrating that structure that pulls all these things together for the important elements. And it's the competence really kind of under one solid rubric. What you see here is that all of these things are there, including the independently executable, that in a certain time frame, and they require certainly knowledge, skills, and attitudes. And it's actually, again, remember, it's using that knowledge, skill, and attitude, which is so important. And that's really kind of the key properties of the EPA. You know, what it really is you're helping to see the elephant, right? You're not looking at these bits and pieces of an individual, but really how they function in the work environment. And that's really critical. So, well, what are they? Well, the EPAs actually were defined, and the board has put a lot of work into this. They originally had a scoping council, and this was under the leadership of George Shirosi. And they defined the core activities of a general surgeon. And understand, this is the floor, right? This is the floor of the specialty. It's not the ceiling. And so they also looked at to make sure these were able to be meaningfully assessed in all training programs. So this wasn't set up for places that had completely high-end, everything quaternary, tertiary care only, but truly every training program should be able to accomplish these. So again, that's the concept of the floor. And this was informed by currently available data on resident and post-training practices nationwide. In other words, what people actually do in residency and what they do otherwise. This is a better schematic of it if you think about it, sort of from a body standpoint that Vanessa Lindemann put together. But what you see here is it really does kind of capture a large amount of areas. We had the original 5 that were the first 5 that the pilot study went out for, and then an additional 13 have been added at this point. And this work obviously involved a lot of work, needless to say, online, in person, as well as continuing collaboration right now with a lot of key stakeholders that you see here, education leadership, including the APDS, ACGME, ACS, American Board of Specialties. And truly thousands of hours have gone into this effort with really one goal, and that's improve the standardized quality of the training experience. And by doing that, by that experience, hopefully improving or continuing to assure the improvement of the product at the end. So the steps of developing just to give you a little kind of sort of the how the sausage was made, if it were, in the process. But developing the EPA really included, step 1 was really defining those functions that were expected for the competent provider. Then the goal there was to map those to other existing competency models, specifically the milestones and the competencies themselves. And then defining specifically directed observable behaviors. In other words, what could be identified when you're looking at somebody in the real work environment that can be exhibited at various levels of entrustment during that pathway to competency. And I want to show you how this is broken down. And again, I know this is a kind of a busy slide, but again, you'll understand this, I think, helps you understand how this was processed. But initially, this is an example of some of the functions. And so if we're looking at gallbladder disease, some of the functions at pre-op would be, again, synthesizing essential information from the records, cost-effective workup, all of this. So these are the functions we would expect someone to actually be able to do: workup, diagnostics, informed consent, et cetera. Now, similarly, there's similar functions in the interoperative aspect, identifying the critical view of safety, for example, being able to form a cholangiogram, and then post-operative elements, managing various complications that you may identify. What was done there is these were the functions. Now, how did they map to the milestones themselves? And what you'll see here is these are several of the EPAs going across the board, but all of these were actually mapped then to various milestones, and they were integrated to the competency assessment. And the hopes are then, if you think about it, if someone then becomes, for an EPA, completely entrustable, for example, thyroid, parathyroid, then the concern about trying to identify what competencies from the milestones they've met really go away. This can move right into that, to where this will help the CCC identify, well, if someone is achieved the EPA appropriate, then they have actually met these other competencies. So the idea of these kind of merge together. So we're not trying to add on, but really trying to, as they describe, kind of add by subtracting some of the things that are required. Another example you see here, some of the MAP milestones that are there. A lot of these really fit almost all of these. When the preoperative, as you might imagine, the PC1 for diagnostics and the like. So they really can map depending on where they are. Not all EPAs hit all milestones, but by the time you get through most of them, almost all the milestones have in fact been met. Well, the EPA behaviors that you're going to use, and this is sort of what, I won't say what it's going to look like, but this is a bit of what the information is going to be there, is that micro assessment of that resident performance. This is an example with respect to the trauma evaluation and management. And what you see is it characterized by the entrustment levels, right? And if you look over to the screen left, you'll have several levels. You'll have the limited participation, and we're going to go through those as well. And each of those now have specific set markers that you can look for. And this also hopefully will help inform the CCC. So again, if you see someone is at limited participation, but they're able to do that, then they might be able to achieve, for example, PC2 at a level 1. So this not only gives you the competency, but also allows the CCC and the department to identify at what level they are. And quite frankly, it gives the opportunity for the learner to understand that as well. Now, with the APAs, they're involved, we talk about preoperative care, and we see here the learner can move from basic knowledge through incomplete data, gathering incomplete data, to all the way up to a truly complete comprehensive assessment with communication skills to progress layer over layer. So for example, at level 1, knows basic anatomy, obviously then moving on to making generic H&P versus a targeted H&P, all the way up to eventually overseeing complex patients and problems, conducting the full informed consent for a complex process. Same with the interoperative, same concept, right? A lot of 14 of the EPAs do have an interoperative phase. As you might imagine, several of them do not. But the learner progresses again from that basic cognitive knowledge of anatomy and operative steps, meaning they can tell you what to do, but they can't actually do that, all the way through routinely recognizing tissue planes on routine cases. And finally, the ability to actually perform safely in a more complex setting, which is what we're trying to go for. And then finally, post-operative, same concept, right? 14 of the 18 EPAs have a post-operative aspect as well. And this is also progressive entrustment, as you can see, involves capable management from straightforward to the actual complex communication context, critical conversations with the patient and caregivers, and the like, conflict resolution. Now, the levels of entrustment we were just talking about, as you see here, limited participation all the way up through can teach others. Now, I'll say this, the board is still having some challenges and some debates about whether the at level 5, the can teach others really needs to be in there. There's at least rumblings, I will say. I'm not sure. We'll see what happens at the very end when it happens, but that it probably will not be included in the final project. So the final product will probably be a 1 through 4 at this point, as opposed to 1 through 5. And what you see here is a good example showing, like, for the interoperative phase on the right side, on the right side, where you see as you move through the interoperative phase of gallbladder disease from level entrustments with very specific anchors on what learners are supposed to be doing. And this level of entrustment will be granted the next time based on what you've witnessed this time. And that's the main goal at this point. So there are a few other themes out there, as you might imagine, that do fit within some of these, including patient safety, cost effectiveness, and coordination of care. These are also within the EPAs that you'll identify in certain areas, including personal learning plan, timeliness, as well as evidence-based practices, put in a lot of them as well. So the opportunities that what evidence is there. So it sounds good. All right. And this is sort of I'm going to give you a little bit of the how, in the sense of how some people have done it in the past with respect to the pilot program, and then how some people are talking about doing it now. As I think you guys were actually part of the pilot program originally, and there were actually there was going on between 2018 and 2020. The ABS coordinated that pilot. 5 EPAs, as you're aware. Actually, 28 programs volunteered to try and figure out how to deal with this. And you know, there's no question that it was a challenge. Through that period of time, over 1,000 residents were available for assessment, and over 6,000 micro assessments were collected over that period of time. And of note, while surgical faculty performed most of these, some other faculty, including, for example, emergency room faculty, were helpful in capturing some of the EPAs, particularly in that preoperative phase and consulting and the like. And so it really depends on that clinical setting. So understand, it doesn't necessarily have to be just the surgical faculty. The way that other people can be involved in this as well. And of note, the fact that there are a large number of residents available for the assessment, it's actually 10% of the U.S. surgical residents at the time were involved in this initial pilot program. Now, the latter 6-month cycles that went through were really starting to COVID. So we can see the last 6 months, the last 2 rounds of the 6-month period really did decrease significantly. And I will say this, and this is where we get into the concept that it really is kind of a culture change. These are the list of the various programs. And I'm not actually going to say where we are here when we did it, but I assure you we weren't in that top echelon by any means. But of the 28 sites, you can see that there are a wide range of sheer number of observations that were occurred, all the way from the leading program capturing well over 1,000 to some of them captured 0. And so you do understand where this really is a culture change from that standpoint. But with this gave us an opportunity to look at, okay, what have these programs done that have done well and versus those that had the challenges. And one of the highest performing programs had one key feature, and that is really support from the chair and the program director, as well as having champions there as well. But even those, and look at Wisconsin with Rebecca Mentor and Jay Greenberg when he was still there. As you notice, this is a wide range of success. Early on, a lot of success, department meetings, a lot of assessments going in, but it starts tapering off. Went up a little bit at the first CC meeting, then plummeted. But then again, understanding that you had to move through that drift, as it were, and continue to support the faculty, support the residents as we move through this, to understand that it's critical to have this done and continue to have retraining. Because also, I'm sure you're the same way. You have a lot of new faculty coming in, so you have to make sure you onboard the new faculty as well. Or quite frankly, onboard it's okay that if somebody stops using it for a little while, retrain to make sure that the reason why they're not continuing to use it is they're afraid to because they've forgotten how to. So these are the areas where retraining could really make a difference. One of the key aspects also identified when you look at those was that it was absolutely identified that this had to be a mobile app-based collection strategy. And as such, the board has, through an RFP process, contracted with the Simple Collaborative to provide an EPA assessment app, also to allow for secure data collection, and also user-specific, meaning program-specific dashboard reports for the programs nationwide. And this cost is being borne out by the board, not the program. And the general elements that have been included in the EPA microassessment, and when the assessor will be able to open up the app on their mobile device, choose a trainee being assessed, the specific EPA, choose the complexity level, and then go through the narrative, the level of entrustment, and then discuss the narrative feedback as well. Now, the materials that the faculty, residents, and program directors, residency coordinators, and CCCs will be able to use for their development are in use right now, but this will also be provided by the ABS, including things like other webinars will continue to support as those onboardings needed, town halls, frequently asked questions, and presentations continuing at national meetings and the like. As you see, some of them are going on here. So to get to the so what, or to wrap it up, what we're really trying to focus on is that why or how can you practically use this? Why does it really matter, right? I think, and if we want to talk about cultural change, if you don't have the so what part of it, then you're not going to succeed. Where is the value, in other words, right? Well, interesting enough, and the data from the pilot did allow us to make several evaluations of inferences from some of this information. And again, data from the Wisconsin group was used during the pilot program, and we looked at this closely. And there is an indication that resident autonomy actually increased and improved during the use of this tool, meaning the EPA itself. And the other factors were certainly at play during the COVID time, so it decreased a bit at that point in time. But that particular Wisconsin's ACGME percentile for teaching assistant cases went from the 71st all the way up to 91st, and then finally all the way up to 94th percentile. And they really felt it was likely due to the fact that it was attributable to using this EPA model and its impact on the faculty and the residents' perceptions of themselves. It's both faculty and residents' perceptions of their abilities. So this also helps the residents themselves. Additionally, they looked at some of the natural language, and this is some of the nice things that are occurring at this point in time. And this is kind of the future, but this does suggest by looking at natural language, what we can do is that downstream, perhaps AI-based strategies may even allow evaluation of entrustment off of a template of dictated feedback in a potentially automated fashion. Now, this is to come, right? This is not version 1.0, but certainly version 2.0 or 3, we might have an opportunity to do this. So these are things that, understand, this is an iterative process. And there are going to be some bumps along the way, and we're going to need to know about those bumps so we can help improve them. This is one of the fascinating things I will say, and even better importance. And I'm sure many of you are aware that there's a lot of data that suggests that there are some gender biases with respect to faculty assessment. But one of the nice things here is having that anchored nature of these assessments really hopefully will help mitigate some of those gender biases. Anecdotally, one of the points of feedback from the residency administrators coming out of the pilot was that the behavioral anchoring feature also created an area for the faculty themselves to feel safe, if it were, or a safe mechanism to give that feedback. You know, I don't know if you guys have the same problem, but a lot of times we've actually gone to group evaluations at the end of the rotation because a lot of particularly junior faculty are concerned about actually being completely honest on the evaluations because they're afraid that if they give fair feedback, that will they get inappropriate feedback back as well. So this gives you a really safe mechanism in the sense because these are really anchored specifically. Another thing I would say is, and we found this as well with the self-efficacy work we've done, which is again a little off topic, but because it's a whole grand rounds unto itself, but that we've also identified that female trainees oftentimes have a lower self-efficacy, despite the fact that their feedback from faculty was actually better than some of the male residents. So again, this gives an anchoring not only for the faculty, but also for the residents so they can identify where they can do and hopefully get rid of some of these biases that actually exist. And then finally, I think the EPAs, they really are a great structure for providing that frequent microassessment that captured in a timely fashion. And the whole goal here is that this will hopefully ground those CCC conversations when we're looking at the competency of residents in that whole concept of the more holistic process. And then hopefully as the IT system and data integration occurs, this will just be automated function as opposed to having to do any of this as well. And there's certainly future implications with respect to how case logs fit into this, milestone mapping, and whether actually case logs will even be necessary anymore. You know, now in the end, how will it be used? Certainly, again, the data is going to be held securely by the Simple Collaborative, and it's specifically for the programs. Understand, this is for the programs, right? It is not for the ABS. It is the program's data and information. Yes, it will certainly have to be, a summary will be sent back to the board for all applicants for the 2028 ABS QE. Understand that originally, a lot of people were saying, well, the people that coming in this year, well, it's not really people coming in this year, right? So if you have people out on research, so understand they will be involved as well. So any of those individuals, so it's not like you can just start this year and just use the interns only. You're really going to have to use everybody because anybody that's going to be going out on research will also have to have a summary evaluation itself. You know, people are talking about at the bottom, and again, this will be an individual program choice, but if you think about it, the numbers over time, if you even just did 2 assessments of a resident per week, that allows up to 50 per resident per CCC and over 500 over the course of a residency. And understand with faculty out there, you're sitting here thinking, oh no, am I going to need to understand all these 18? Realize you've got 18 there, right? But you're probably only working with the resident typically in a few areas. You know, maybe the EGS service might have a lot more than that, but if you think about it, if you're on the endocrine service or the breast endocrine, however your service is set up, predominantly you're dealing with thyroid. If you're dealing with the MIS service, typically you're dealing with hernias, perhaps some of the gallbladder and the like. So you're not necessarily going to have to be comfortable with all 18. And so this really does give you a chance to really understand the anchors very well. So it really shouldn't take a tremendous amount of time. In fact, most people have identified once you get comfortable with this, it probably only takes about 2 minutes to get it completely finished. Now, what about the whole idea of time variability? And this is in process, right? How is our system going to be able to handle this competency model for those that require more or less time? this is really part of a larger discussion that is ongoing. But in the meantime, as I said, the system itself really can create some of the flexibilities for residents who do meet competencies before the completion of training that might be great for career and personal benefit while they're still being managed in their own program structure. And again, that depends on the program itself, how you can do that. But if you think about it, if someone has become completely competent at doing, let's say, gallbladder, do they really need to be doing another 10 or 12 gallbladders? No. And that gives you the opportunity. Perhaps they can then become that teaching assistant and again, push some of those things downstream so everybody continues to improve. So these are areas that I think we can really focus on. And then finally, focusing really on the constant and quality of the graduate. There are a lot of other opportunities out there to look at information beyond what I've spoken here today. On the website, you can see, you can click on EPAs from there on the top banner. You scroll down, there's actually frequently asked questions section. There's an upcoming event schedule, various publications on EPA, continuing timelines, and as soon as things roll out, and also again, opportunity if anybody else is interested in rolling out and being a champion for your own program, you can do that as well. This is a partial list of some of the content that we got for this talk itself. You can see a large number of people that put a lot of effort into this. And certainly there are a larger number of volunteers that have been involved in this project and will continue to be. And so what I'd like to say is I really appreciate the chance to share with you some of these aspects of the way this has been created, hopefully a little bit about why it's been created, and that hopefully we can continue to serve you and the training program in the initiative. And I'll be happy to take questions at the end as well. And I'll stop sharing.
Thanks, Dr. Korndorffer. For kind of how we've set this up, we're going to definitely allow time after Dr. Marquardt's presentation to kind of talk about next steps for us and context of us rolling it out for our complex system. And so what we already have some great questions by Dr. Langdell. So keep on putting your questions in the chat. We're going to roll on next to Dr. Marquardt and then definitely do Q&A for a good, hopefully 10 to 15 minutes. You're on mute.
Sorry, I realized I was on mute. So yeah, I'll try to move through this expeditiously because we really do want to have time for questions. Dr. Korndorffer, I really want to tell you how much we appreciate you being here and being willing to sort of share on the part of the board and also to be here for our Q&A. I'm just going to briefly go over what our program and program leadership really feel like are the huge benefits that this is going to bring to us as a program and really to general surgery training nationally. So you're going to see a number of slides that I've actually brought from the facts page from the board website. And I've just listed there, again, the sort of the link to get there. So there's a lot of great information. So just wanted to share that I have borrowed slides intentionally. So, you've heard EPA is really designed to address specific activities related to a given diagnosis with clear entrustment levels linked to that behavior. And again, this is reiterated. You see the entrustment levels that have really been designed as the key feature from limited participation to practice ready. So, the ABS EPA program takes the evaluations that we already actually do as faculty and really focuses them into readily accessible and easy to complete microassessments. There's several substantial steps forward offered by the assessment program and tool. As Dr. Korndorffer has already highlighted, the residents receive feedback that's actually anchored in a specific level of achievement around a given task. Faculty from various sites and rotations can actually review resident feedback for a specific APA or a piece of an EPA, and then use this to collaboratively advance an individual resident's progress toward greater autonomy, right? Instead of kind of recreating the wheel with each new rotation that a resident goes to, gee, I haven't worked with them in a while, I don't really know what they can do. This really is a collaborative process. And as Dr. Korndorffer also highlighted, this really, due to the anchors, we feel is a huge step forward to allowing our program to kind of be focused in this assessment and to decrease our bias through the anchors. So, 18 EPAs is a lot and certainly is just part of general surgery practice. But, as the question was asked for, do we all really need to do all 18 EPAs? So here again is the picture from the board website of all the different EPAs. These are obviously meant to be the core, but looking at the titles, they make a lot of sense, but it's a lot of stuff for any one faculty member or resident to consider. So really, as kind of alluded to earlier, we're really looking at not 18 for every individual faculty member, but really looking at 2 to 4 key EPAs per service. So everybody doesn't have to be all things to all people at all times. So most services in the UW Department of Surgery, as said, will have 2 to 4 EPAs that really best map to their daily practice. The goal is for faculty on a given service to learn and master these as their key focus. That will lead to ease and efficiency of completion. Again, looking at probably 1 to 3 minutes once you get familiar with that EPA to really do your assessment. Oh, and I'll highlight, at the bottom, we kind of listed, we have gone through and kind of done a mapping of all the EPAs to all of the different rotations that residents rotate on in our program. And certainly, this was just our stab at a map. You all as individual services really need to look at this with your champions, and I'll get to that in a minute. But for example, Harborview may do a lot of the soft tissue infection, trauma, and critical care, whereas Northwest, with a lot of acute care may do appendicitis, surgical consultation, and inguinal hernias, right? So, not all things to all people. Choose the things that you actually already do in daily practice that makes sense. So, as already shown, each EPA is completed on a mobile app. The determination of an entrustment level is defined. And then at the end, you have the opportunity to give a short dictation to really provide that little bit of verbal feedback that can kind of encapsulate what you've already done based upon the anchors and the entrustment that you've assigned. So what are the faculty and resident goals that we're setting out locally? These are quite similar to kind of what the board has at least given us some guidance up front. So for the residents, our goals is that they are sort of requesting 2 to 3 EPA microassessments per week, which really is profound when you think about that. Gives them 100 to 150 EPA microassessments per year instead of, it's great that we'll talk to them at the end of the case. And sometimes you can remember those things, sometimes you forget them, but these are things they can go back and review versus just the end of rotation feedback, plus or minus whatever feedback you get more or less from various faculty members. For each faculty member, we're looking for faculty to set a goal to maybe complete 1 EPA microassessment per resident level that you work with each week. So for example, on the general surgery service here at the VA, I have an R1, an R3, and R5. So as a faculty member, I'm gonna shoot for doing 1 assessment for the R1, 1 assessment for the R3, and 1 assessment for the R5 each week, which adds up to somewhere between 6 to 10 minutes of my week, which is really not that significant, but I think really provides an immense amount of value for our trainees. So as already also discussed, the full reporting on this evaluation program will be required by the board for all graduates presenting in 2028 for their qualifying exam. But we obviously are planning to roll this out as an evaluation process for all of our general surgery residents at all levels beginning in July 2023. And really, I'm just going to reiterate the excellent reasons why we're doing this globally. So it's really a substantial programmatic improvement for the feedback that we're already doing. It just allows us to collaborate better across sites to progress our residents' autonomy. And it really helps us in our ongoing efforts to decrease bias and increase our entrustability. I hope that just hearing a little bit about this today has convinced you, or maybe at least begin to convince each of you of the benefits of the program that we're going to launch. And I'll briefly comment on where you can get help in this process, because we have really already identified some champions. So over the course of the winter and the spring, local service and site champions have been identified. All of these individuals have already gotten kind of a head start on reviewing this program, getting to know what it's about, and thinking about plans to implement the platform and assessment tool to the best effect of the daily workflow of each work site that's out there in our system. You can see the consensus evaluators for each rotation, and sometimes there's actually a different consensus evaluator per resident level on a given rotation. Those individuals have been listed as our key champions on a rotation basis to reach out to who already have, like I said, received background and training on this, and we're continuing to work on that. And then the associate program director at each practice site is also a resource. You can see all the sites listed. For the residents, each of your champions are your REACH member for your PGY level. They've also been involved in kind of getting to know this process, how we're planning to launch it, and sort of how to make it work for our system. So new things, of course, are always a little hard and to get into the habit of doing. So we are implementing a feedback process to provide reminders to assist everyone, both residents and faculty, to successfully participate in this process. So there will be bi-monthly tracking of microassessments completed for each service that residents rotate on, and tracking of microassessments completed across members of each resident family. Now, the residents will know what I mean when I say resident families. For faculty, you will hear more about the Resident Family Initiative that was both derived and developed by our residents to help better facilitate community and education within the program. But that's going to be sort of a forum where we can kind of help them get this feedback and help each other in the process. So actual reports on the microassessments completed are going to be sent bi-monthly to each service across the system and to each resident family bi-monthly. And then we're going to do end of month monthly reports of the same, sent to each division chief within the department, as well as to the program director leadership team for the residency. I think this seems like a lot, but at the end, I just want to say the big takeaway is really that though this is a required program from the board, it's really an excellent program. And it's one that really provides the opportunity for a lot of benefit to the residents and the faculty to provide us, better content, better quality, better expediency, and really actionability of the evaluations that we're already doing for our residents. So before we go to Q&A, I do want to give a couple of minutes to Dr. Andy Wright. Actually, EPAs already are at the University of Washington. The MIS fellowship has already been using this process for evaluation. And so I wanted to give Andy the chance to talk a little bit about their current experience with EPAs.
Thanks, Dr. Marquardt, and thanks, Dr. Korndorffer. We've been using EPAs starting this year. This is a national thing in the Advanced GI MIS fellowships. I would say that my initial skepticism of this was that it was going to take a lot of work and be a huge hassle. And in fact, it really isn't that hard. So I've been a convert to the EPAs, and I hope everyone else, once they actually get some practical experience with this, will also feel the same way. The way we set it up, it is fellow initiated. There is an option for faculty initiated EPAs, but we've asked our fellow to start an EPA, and we've set a goal of 1 per week. You can see an example that we have up here. And as Dr. Korndorffer mentioned, often the faculty we found actually rate our fellow higher than our fellow does, which is pretty typical. But you can see where there's some actionable self-evaluation by the fellow and some evaluation by us. I will say of all of us on the MIS service, actually, Dr. Yates provides the best evaluation. So thank you. I want to shout Dr. Yates out for that. I think a couple of key things about this. Number one is that it is very quick to do. Number two is that at least for the fellowships, this has replaced our required technical skill evaluation. So to Dr. Langdale's question in chat about does it modify other evaluations, I'm not sure if that's the case for residencies. but it actually has reduced some of the paperwork and evaluation burden that we were having to do before. So I think that's been a key to its success.
Well, thank you. I know we actually have 9 minutes and there's a lot of questions and discussions, and this really was meant to be an introduction with a lot of work that's still to be done with our champions and rollout. So we're going to open it up to Q&A for all. We'll go ahead and start off with Dr. Langdell. In the chat, she says, how does this interface with ABS case numbers requirement? We know you talked about that a little bit, Dr. Korndorffer, but for example, competence achieved with fewer numbers than ABS case minimums. Second question is also programmatically, what happens when the opinions for entrustability differs among faculty? Multiple sites in our system with diverse patient populations will impact this.
Yeah, well, I'll take the first one, that programmatically, I guess I'll leave it to you guys, right? But certainly everything's on the table, I'll add to that, right? And case numbers, although this sort of is always kind of been that third rail, so to speak, have been being actively looked at, you know, because I think we all know that case numbers don't necessarily mean much, right? It depends on what those cases are. And so, yeah, I know Dr. Klingsmith and others at the ACGME have been actively looking at this as well with respect to case numbers and working with the board also. So I think there is a real possibility that this has a chance to eventually supersede that concept of case numbers. I'll just put one thing in as far as what happens as far as the different faculty. You know, one of the great things that are that this is based on the specific event, right? And if you notice, it's like it could be someone that is more complex versus basic. So it depends on those kind of what you're dealing with. So that's where those levels come in. And so, you know, I think it really this has been taken into account in a way that, fine, you may have someone that is perfectly capable. And, you know, we do this every day already, right? If you have someone that comes into the ED that is, and you're called by the second year who you know reasonably well, who tells you something about, and it's a classic appendicitis, you're already entrusting that person to say that, okay, they need to go to the OR. Because my bet is you're probably not seeing the patient until they're in the pre-op holding area more often than not in that kind of situation. So you're already entrusting that person. However, the same situation, someone coming in that has an acute abdomen, things don't make sense, you're not necessarily entrusting that same person, although it could be an appendicitis, it's just perforated, right? So you're not necessarily trusting that same person. So you're actually actively involved more so. So I think the whole idea is the diverse patient population is taken into effect as far as the entrustment goes.
Yeah, I was going to make one comment as far as evaluations. Currently, we do the milestone evaluations at the end of every rotation, and in the beginning, those I don't see going away, like in the next academic year or perhaps 1 to 2, simply because we won't have enough data, right? We're just rolling the program out, and long term, because of the mapping across milestones and EPAs, I do anticipate that those will go away, and we won't need those anymore. But I think it's going to take us a little bit of time in order to get used to the program, right? Because the board's not requiring us to sort of perhaps go full steam and do everything up front day one, we're all going to grow in this process. So as we grow and do more of these, I do see those going away and it being, as you say, an addition by subtraction. And Lori, Dr. Langdale, I do think as long as we are, thinking about the complexity level of a case and documenting that correctly, that really does, help you even the playing field to say what you can entrust them with a given resident, given the complexity level of a case.
And we'll go to Dr. Wright in a second, but just to clarify, we were not a beta testing site. We actually used Simple and we're part of the Learning Collaborative in the past. So some folks are definitely have been exposed to the Simple app. And then the second clarification, we are going to roll this out to our general surgery residents, but also include our integrated specialty residents, so that are rotating within general surgery. So all to be collaborative and equitable, we're rolling it out for all of our residents that rotate within general surgery. So we'll go to Dr. Wright.
Yeah, I just wanted to point out that the EPAs as they're currently constructed are very clinically focused and don't pick up all of the things that are on the milestone. So it doesn't, for example, talk about practice-based learning and improvement, and it doesn't talk about things like a team or those sorts of things. So at least in the fellowship, it has supplanted the technical skill evaluations. It has not supplanted the more global evaluations.
I would just add, it's like, as far as the EPAs, the way they were, a lot of those things really were very specifically tried to be added into these EPAs in various areas. For example, with the trauma, it's actually running the team and the like. So there was a very conscious effort to try and capture. We did not capture every single one of the milestones and competencies, but almost all of them are captured somewhere over the 18 at this point in time. For that exact reason, Dr. Wright, is that because there are some areas that aren't typically captured, but even the concept of using literature to make your decisions, things like that, those are actually in some of these at the higher levels, right? But those are some that have actually been added in to where if you really hit all 18 EPAs, you will probably have hit every one of the milestones, save one or two.
While we're waiting for more questions to come in, just in the last 3 minutes, Dr. Korndorffer, you showed us a graph where you had 1,000 micro assessments for one of your beta testing sites and then 0 for another. You know, upon analysis of that, knowing our system with our 7 different sites and kind of hearing our rollout plan, trying to get leadership boards and not having a lag and a good, strong stance going forward. Are there any true must-dos or must-don'ts, any recommendations you have for us?
You know, I think this, and it's been said very well, this goes back to the concept of any kind of culture change, right? You have to have your champions. You continue to realize you're going to fail some, and that's okay too. You know, it's not a concern. You just figure out why that was a failure, and then continue to move forward from that standpoint. I think the whole goal there really is the champions in each level, including at the highest levels, meaning the program director, the site directors, and the chair. Because this is here to stay. I think, you know, I don't think this is one of the 38 or 34 flavors, whatever it is that Baskin Robbins has, you know. I think this is here to stay. It's not the flavor of the day. I think this really is truly a momentous change on how we're doing things. I think, to me personally, the idea of micro assessments are so critical. This whole idea of getting information at the end of a rotation and, you know, you wind up with needs to read more or did a nice job, serves no purpose for the individual and really doesn't help anybody who's trying to make a competency decision on that person. But with the micro assessments, and the way I like in the micro assessments is that, you know, because also we're talking about different places see things differently, is, you know, it's oftentimes the whole idea, if you take that jar of jelly beans and have one person say how many are in there, they're going to be wrong by about 30%. But if you wind up having over 100 people actually make a guess and put all those guesses together, they're almost going to be spot on within 1 to 2%. This is similar to what we're doing here, right? You're getting a lot of opportunity for a lot of people to weigh in. And in the end, you're going to get that nice average. It really shows you where you need to be. And so I think that's another area where I think this will make a big difference.
Well, it's 1 minute to go. We just want to express our sincere gratitude for your time and representing the board and helping us with this complex, but very exciting process for our residents and faculty. The rapid graduated approach, elimination of bias, supported terminology. And we're just really looking forward to working as a program and with our champions moving forward. So thank you.
Thank you for the opportunity. Appreciate it.
Yeah. I want to give one more shout out. You know, everybody's kind of heard a little bit about this who perhaps maybe hadn't before. Reach out to your consensus evaluators. Reach out to your reach level resident and say, like, hey, tell me more about this. What have you heard about this? Because really, you know, we have global plans in place for a rollout, but again, we're going to grow in this. So I think we're looking for people's input and ongoing, you know, thoughts about it to make this the best that it can be, and also to really make it truly like applicable, right? It's gonna to make it easy to fit in your day. So reach out to your local people and get involved because it's coming in July.
All right. Well, thank you for everyone's time this morning. And next steps will be forthcoming.